Thank you so much for having me here at this outstanding conference. I'm one of the hematologists at Children's National in Washington, D.C., and I feel privileged to be at this great conference and talking to you guys, and also honored to be part of this panel of outstanding speakers. I'm going to talk today about bisphosphonate in GSD, GLA, and KLA. I have no disclosures related to this talk. What I would like to cover today in this talk is I would like to first give you some background information to help you understand why we thought bisphosphonate therapy might be helpful for patients who have these complicated vascular anomalies. I'm going to also talk then about bisphosphonates in general, how they work, what's the side effects, and what's the rationale for using them in these complicated vascular anomalies. And then I'm going to provide you some data, as limited as it will be, about use of bisphosphonates in combination with sirolimus. And I'm going to finish by talking about future steps. Sorry about that. So first of all, I just wanted to give you the terminology of that we use when we talk about bones and the effect of bisphosphonate in bones. So the most important part of this slide is, sorry, I'm going to just use, the most important part of the slide on the image on the left is to show you the parts of the bones that we talk about when we describe the bone disease in these complex vascular anomalies. So we have the cortex, which is the hard shell of the bone, and then we have the spongy part of the bone, which is inside the shaft of the bone. And then we have other parts of the bone, like the bone marrow and the blood vessels that go through the bone. The other important part on the other image on the left is the differentiation between types of bones, and this is important in differentiating the types of bone disease in these different vascular anomalies. So we use the terminology axial bones, so these are the skull, the ribs, and the part of the spine. And then we have appendicular bones, these are the extremities and part of the pelvis bone. And then the other thing that I wanted you to understand is the physiology of bone formation and bone resorption. So normally there is this continuous bone remodeling process where there is cycles of bone resorption, bone destruction, and bone formation. The bone resorption is done by cells that are called osteoclasts. And the bone formation is done by cells called osteoblasts. And that's usually balanced in a fashion that maintains the strength of the bone to be normal and allows for growth of bones. Just, you know, this slide just to show you that the most recent revised ISSVA classification of vascular anomalies now includes KLA as a subtype of GLA. So this has been sort of discussed previously in yesterday's session about the distinction of the bone disease in the different types of complicated vascular anomalies that are associated with bone involvement. And we now have better data and are able to distinguish this phenotype based on the degree of bone involvement and how many bones, and etc. So this just summarizes that for GSD, the hallmark is that we see progressive, extensive bone destruction that almost always destroys the cortex, that's the shell of the bone. That's the hallmark of GSD. We oftentimes see, unlike GLA, we see that fewer bones are involved in GSD, and the types of bones that are involved are the axial bones. So most commonly we see it in the ribs and skull and vertebra, but it can be seen also in the appendicular bones less commonly. Typically, the bone involvement is contiguous, which means it's the same area of involvement that extends across the bone and often is associated with soft tissue involvement. Now, GLA, and you guys have seen yesterday these characteristic punched out lesions. This is very characteristic of GLA. You see multiple lesions that are described as punched out. They typically are not progressive like GSD, but they can increase in number and size over time. Unlike GSD, and this is a big distinction, is that the cortex is preserved. And then we actually see a little bit difference in the number of bones that are involved. Usually you see multiple bones, more bone involvement than GSD. And we typically see both appendicular and axial skeleton involvement. And typically we don't see adjacent soft tissue involvement like GSD. KLA is actually, in terms of when there is bone involvement, it's not always that you see bone involvement in KLA. It's very similar to GLA, but it has predilection for involving the vertebra, especially the thoracic vertebra, because KLA has this predilection for involving the chest. And then we don't really understand yet fully the mechanism of these diseases. We still are learning a lot. And why there is this predilection for bone involvement is also not well understood, and there is a lot to be studied for us to be able to know why they have this bone involvement. What we know is that in the bones that are affected, there is, when we do biopsies, we see this abnormal proliferation of lymphatic channels. That should not be there, that are abnormal, and that are responsible for the disease. Now, there is what we call as indirect evidence. It's not very clear, but there might be some activation of the osteoclast cells that I mentioned before. Maybe this is induced by the presence of these lymphatic channels. We don't know, but there is some evidence that suggests that there is osteoclast activation. And I wanted to show you some pathology slides that shows, Dr. Briones showed one similar to this. So the upper one is from a patient with GLA, and the lower one is from a patient with GSD. And then what it shows, if you look at the upper left slide here, A, and all of them, it shows these abnormally dilated lymphatic channels, which is characteristic of both diseases. What this slide shows also is these osteoclasts that I mentioned, and this is in the upper slide in image D, and again in the patient with GSD, it's in slide D. So these, the arrows in image D in both slides show the osteoclasts, which are present in increased number in the bony lesions. And then the special stain that Dr. Briones mentioned pretty much established that these are of lymphatic origin. So what are bisphosphonates? Bisphosphonates are drugs that work to increase the density of the bone by inhibiting osteoclast. So they target osteoclasts, and there is a complicated mechanism of how they actually inhibit osteoclast. So essentially, they make the cells that destroy bone, they make them less active. And when you slow down the destruction of the bones, you tip the balance towards more bone formation. These drugs have been in use for many decades in adults. There is limited experience with using them in pediatric patients. These are the drugs that are often prescribed in adults for osteoporosis. In pediatric patients, there is some limited experience using them in some forms of secondary osteoporosis, but also in genetic diseases, like there is a disease called osteogenesis imperfecta, where there's some experience. But overall, the experience of using bisphosphonate, which is an issue in pediatric patients, is actually very limited. And this table just shows you that the bisphosphonates that are currently used in treating bone disease, and some of them are older, some of them are more recent, and they vary. They can be oral or parenteral or both, meaning they can be given IV or orally, and they vary in potency. Some of them are very potent, so the most potent is zoledronic acid or Zometa, which has the most the strongest effect on osteoclast inhibition. It's interesting, in pediatric patients, you will see that the most experience is with bisphosphonate called pamidronate. But when we talk about vascular anomalies, most of the case reports and publications have been on using Zometa or zoledronic acid. So what are the potential side effects of bisphosphonates? So there are possible short-term side effects. And one of the more common short-term side effect is this acute phase reaction. And that usually happens with the first infusion. It's essentially like a flu-like illness where patients experience fevers, myalgias, chills, and can be sometimes very severe. In most instances, it's actually mild and potentially preventable with pre-medications. The other issue with the other potential side effect of using bisphosphonates is because we are essentially slowing down the osteoclast and tipping the balance towards more bone production, the calcium in the blood goes into the bone, and there is increased consumption of calcium. So potentially you can get low calcium levels, especially acutely after giving the bisphosphonate. It can cause bone pain. This has been described. And this complication that involves the eye has been described, but it's actually very rare in pediatric patients. In terms of long-term effects, and that's very important for us to understand, especially if we start using these drugs long-term for treating complicated vascular anomalies, we really don't have a lot of data. One thing that we worry about long-term use of bisphosphonates in pediatric patients and in adults is possibility of tipping the balance the other way, where we make the bones too much dense. We call it brittle bone syndrome, because the bone has to have a certain density. If it becomes too dense, it actually becomes fragile. So that's a potential issue of long-term use. We don't know what's the effect of using bisphosphonate for years on a growing child. There is no data. And there is this potential side effects that has been seen in adults where there is calcium deposition in kidneys. That's a potential side effect. And because these drugs, the way they work, they actually get deposited in bone, we don't know what's the long-term effects of using these drugs for many years and the deposition in bones. So why did we start using bisphosphonate as an adjuvant therapy or in combination with sirolimus in these complicated vascular anomalies? The first thing is that we see significant bony disease in a significant number of patients with especially GSD, but also GLA and sometimes KLA. And that can cause significant complications, significant morbidity to patients. It can cause fractures, pathologic fractures. It can cause deformities, and it can cause pain and functional disability. The other thing is that, as I mentioned previously, that there is some indirect evidence to suggest that in patients who have these types of bony diseases and in GSD, GLA, and KLA, that there might be some osteoclast activation. So it sort of makes sense to target the osteoclasts. There might be, and this is indirect evidence extrapolated from studies done in adults with cancer, there might be actually some anti-tumor activity which might be beneficial for patients who have proliferation of their lymphatic vessels. And then there is this idea, and this is not directly in patients with vascular anomalies, that if we combine bisphosphonate, specifically zoledronic acid, with sirolimus, that we get this synergistic effect, which means that the combined effect of the two drugs is actually stronger than what we expect on the mTOR pathway. And that may be actually an advantage of using these drugs in this situation. So it's very similar to, Batman and Rubens. I don't know if anyone is a superhero nerd like me, but I like. I wanted to share with you now some data on using bisphosphonates, and I did some quick literature search. It's not by any means very extensive, but just to help you see what has been reported so far. And this includes just published reports. I didn't look at abstracts and unpublished data. So this is I'm not going to go over the slide, but this summarizes all the published reports of using bisphosphonate in combination with sirolimus for treating GSD, GLA or KLA. Now, what I found is that almost all of the case reports are in GSD patients. I actually did not see published reports of using it in GLA specifically, except in one paper that looked at both GSD and GLA. I didn't find any reports in using it in KLA. So there is very limited published data on using these drugs, although they are being used as we speak. So I wanted to then, another piece of data that I wanted to share with you is a multi-institutional study that we did that looked at 5 different institutions, including our institution, but also Boston Children's, Texas, Kentucky, and Children's Hospital of Illinois. We wanted to look at the combined experience of 5 centers because we know the numbers are very small in each center. And we wanted to look at patients who had GSD or GLA who received this combination therapy, so sirolimus plus a bisphosphonate. And we wanted to look at their clinical characteristics, but also wanted to see if we can look at how the bisphosphonate were given and how the responses were assessed, and try to see if we can look at efficacy and toxicity. So the 5 centers had 19 patients that we could include. 11 patients had GSD and 8 patients had GLA. The median age at diagnosis was 8 years, although there was a significant range from a neonate all the way to a 47-year-old adult. And the presentation, as often reported, was highly variable. And this table I'm not going to go over, but summarizes the presentation of the 19 patients. And it was highly variable. The other thing that was highly variable is the extent of the disease, as summarized in this table. But it did actually show the same distinctive phenotypes that I talked about before, where in GLA patients there is multiple bony lesions and often multiple system involvement that with preservation of the cortex, and it's not usually lead to progressive destruction of the bone. And in GSD patients, we see less bone involvement, but more destruction of bones. So it sort of was consistent with these distinctions that I previously described. In terms of treatment, what we found is that the sirolimus pretty much was standardized. It was similar to what Dr. Turner has described. It's the same protocol, which is the same dose and roughly the same targets. But the zoledronic acid, which is the bisphosphonate that was used in all 19 patients, we looked at the dosing regimens, and it was very variable. There were patients who received 1 or 2 doses, and there are patients who received many doses and continue to receive it. in combination with sirolimus. The dose itself was highly variable, so there was no consistency whatsoever in terms of the zoledronic acid dose or protocol or how long it was given. The supportive care was very similar in most institutions, and another very variable assessment that we found is how response was assessed. So is it clinical, is it radiologic, is it both, and what should we use in terms of radiologic response? Some used MRIs, some used MRIs and DEXA scans and bone scans, so it was very variable. A lot of patients received other therapies before they were switched to sirolimus and bisphosphonate, including chemotherapy. And when we looked at the clinical outcomes of these patients, in general, the combination was efficacious. We can say based on this limited retrospective data that 2 of the 19 had actually improvement on their disease, and the rest had stabilization of their disease, which still is considered a good efficacy. There was no, at least from analyzing the retrospective data, we didn't see any progression. But in terms of toxicity, it actually was very tolerable. We didn't see a lot of significant toxicities. This table summarizes the adverse events that was reported. Most of them, as you can see, are grade 1. Grade 1 means that this is the lowest degree of the side effect. And as you can see in this table, the most common side effect was this infusion reaction. And then I'm going to skip this case. I just wanted to give you the conclusions from the study. So what we concluded is that sirolimus and bisphosphonate, they appear to be safe and effective. We noticed this issue with variability in diagnosis and treatment protocols and how response is evaluated. And we need a consistent regimen and how to assess response. So that's part of the future steps. I think we need to have to establish uniform criteria for diagnosis and, most importantly, response assessment when we use these drugs. We need a standardized dosing regimen. Everyone is doing something different. And I think it would be helpful to collaborate with people who have experience with using these drugs, like pediatric endocrinologists and orthopedic surgeons who have experience in bone health. And we need a prospective multi-center clinical study. These are rare disorders. We need a study similar to the sirolimus study where we can use both and try to answer the question whether adding bisphosphonate is helpful or not. And finally, I want to acknowledge the LGDA committee for their invitation, especially Lisa. I want to also acknowledge Dr. Adams, who was tremendous in helping with this talk and with the study I mentioned, and with the collaborators. Some of them are here. And most importantly, I want to acknowledge you, the patients and families, and our patients and families that we see. Thank you very much.